to record the class. Okay, thank you. So let's start. We'll be doing the development of the digestive system and related glands. And what are we covering today? Today we'll be covering the tissues of origin of the gastrointestinal tract and its associated glands. So we'll talk about the origin of the esophagus, origin of the stomach, and the various intestines and the associated glands. So that is the pancreas, the liver, and even we'll touch a little bit about the salivary glands. Then we'll talk about the derivatives of each part from the primordial gut. Remember, we should talk about the GIT coming from a tube. So what are the various derivatives, the tissues of origin, from the various tissues of origin of this primordial gut. Then we talk about the vascular territories of the GIT and the embryological basis. Maybe you've been wondering why one part is applied by celiac trunk, one part is applied by superior mesenteric, and the other one by inferior mesenteric. So why do we have those differences? The other one will be to describe the development of the foreguts, the development of the midguts, and the development of the hindguts and their derivatives. And then we'll finalize by, okay, not the finalizing, we'll talk about the various congenital anomalies of the GI, that is foregut, midgut, hindgut, and maybe try to explain the embryological basis. Yes, but before then, maybe we can talk a little bit regarding the glands. We talk about the origin of the various glands, the spleen, the pancreas, the liver, and their embryological basis and their anomalies. Okay, I guess we can start. We can start by looking at the components of the digestive system. So when you're talking about the digestive system, you know the functions of the digestive system is the one that allows the digestion of food to take place. And of course, we usually start with the oral cavity. Here we have the oral cavity. Maybe I can use, we have the oral cavity here. From the oral cavity, you go to the pharynx. From the pharynx, the esophagus, then the stomach. Then you go to the small intestine divided into the duodenum, then the jejunum, then the ileum. From the ileum, you have the colon, starting with the appendix, the cecum, the ascending, transverse, descending colon, the sigmoid colon, the rectum, and then the anus or the anal canal. So that's ideally the image that is on our left shows us the gross bit of this GIT that you're talking about. The related glands will have the liver and the gallbladder there. And then we can see here we have the pancreas. This is a spleen. Spleen is usually like behind the stomach. Remember, the spleen is one of the structures that form the stomach bed. And then you can appreciate the various salivary glands here, with the major ones being the parotid, sublingual, and submandibular glands. So that's the image on our right. So that's just a minute. I'm receiving a call. Just a minute. I respond to it. Okay, apologies about that. So we were talking about the gross bit, which is the image on our on our left. The image on our right now shows us the histological organization of the digestive system. That is the tract itself. So you'll have four major layers. We talk about the mucosa. The mucosa containing this is a lining epithelium. You can appreciate is a lamina propria with some lymphatic tissues, and then you can appreciate the muscularis interna there. So the mucosa will be standard. That is a mucosa that will be standard in the whole of the GI. Then for the submucosa, we can appreciate you'll have some mucosal glands, some blood vessels. Some of them will have these submucosal glands will be prominent. For example, now in the duodenum we have the Brunner's glands. You can appreciate some blood vessels, then there's a loose areolar connective tissue. Then the third layer will be the muscularis externa, comprising of inner circular layer and outer longitudinal layer. But of course, we know at this point they will vary according to the various regions that we'll be talking about. And then on the outer layer, we'll have maybe serosa stroke adventitia. And maybe the people who were in my session last week, you can remember I talked about the serosa being stratified squamous, being simple squamous. And that is what you can see here. This serosa and even the adventitia is simple squamous epithelium. It's just that. And then you can see a very small connective tissue just beneath it. And then, of course, being connected by the mesentery. So if it's connected by the mesentery, that tells us that is simple squamous. And that is now the serosa. If it's not connected to the mesentery or not covered by the peritoneum, that means it will be adventitia direct. So let's talk about the embryonic folding. Maybe as I do this, I like to engage a little bit. Maybe someone can be putting in the chat box, what are the results of transverse and longitudinal folding? What do you think are the results of transverse and longitudinal folding as I try to talk about this? So I'll take you back to the three germ layers. Remember, you have the image on our right, shows us the process of at least at this point, I can be able, I'm sure you know the process of gastrulation, how it comes across. So remember, you have the endoderm. This is the endoderm being somehow the inferior layer or the layer that is just below. Then you have in between, you have the mesoderm, and then you have the ectoderm on the superior aspect. So remember, this is the yolk sac, this is the amniotic cavity or the amniotic sac. Then what happens is that you'll have the differentiation of the mesoderm into three parts. You have the paraxial mesoderm. Of course, you know the derivatives of the paraxial mesoderm right now, the axial skeleton and the rest of the structures. Then you'll have the intermediate mesoderm. We'll talk about that maybe next week or the week after that. We'll talk about the derivatives of the urinary system, the urogenital system, in short. And then we talk about now the lateral plate mesoderm, which is divided into splanchnic and parietal. Splanchnic because it covers the viscera. Then parietal because it aids in formation of the lateral body. So this is now the process of neurulation. You can see it here. You have the neural groove. This neural groove will give us the neural tube, and the rest of the structures will follow up. Given we have the neural crest, and then this neural crest actually will migrate into the GI. Some of them will migrate into the GI to give us the enteric nervous system. The image D here, you can be able to see, we have already differentiated the mesoderm. We can appreciate the process of folding is happening. And at this point, this is lateral folding. And this lateral folding is leading to formation of, first of all, the primordial guard. So you can see the oxac becomes incorporated into this developing embryo. Developing embryo that you can see here. These are actually the two dorsal aortas, and then this is a notochord. So the two dorsal aortas, they help in formation of the primitive heart tube. And this is actually a very common question in terms of, you can have a question like telling you to name these structures. Yeah, so that's one of the results is now due to lateral folding or the transverse folding, you'll have this yolk sac. And this yolk sac is being made up by the endoderm. You can see it here. So this endoderm, the inner lining of the primordial gut will be formed by this endoderm. You can see it there. And then that means the whole of the lining epithelium of the whole GI, apart from the stomodium and even the anus, the outer part, all of the rest will have, that is the cloaca, all of them will have its origin coming from the endoderm. The rest, that is the stomodium, and now the stomodium and even the cloaca, the distal aspect of the cloaca, will be coming from the surface ectoderm. So that means even its epithelium will be different. So the stomodium, the mouth, the oral cavity, and the anus, the cloaca, the distal aspect, will have stratified squamous non-keratinized epithelium, while now the lining epithelium will have, now apart from the esophagus, which will have stratified squamous non-keratinized epithelium, the rest will have simple columnar epithelium. So that can help us to understand the origin of the lining epithelium. So maybe at this point you can appreciate this splanchnic mesoderm. And this splanchnic mesoderm will be involved in the folding, like it will cover the endoderm. So that means talk about the musculature, talk about the serosa stroke adventitia, and even the other part of the mucosa of the GI, it will be coming from the splanchnic mesoderm. So I hope you can be able to see that. So remember, splanchnic mesoderm can also be referred to as visceral part of lateral plate mesoderm. So why is it called visceral part? Because it covers the viscera of the GIT. So it covers now the endoderm and the structures. So that is the transverse folding. The image now on our right shows us the longitudinal folding. And the reverse of the longitudinal folding, we can see them there, is that here we have the heart tube and the diaphragm and the septum transversum at this point. They migrate downward due to this longitudinal folding. The other thing you can appreciate is now you'll have the yolk sac. Remember, we have the primary and the secondary yolk sac. So a larger part of the yolk sac will be removed from this developing gut, as you can see here. Then at this point, when you have this folding, at least you can be able to see the bucopharyngeal membrane. This bucopharyngeal membrane just demarcates the place where you'll have the future stomodium, the cloacal membrane. Maybe this one is important. You cannot, the allantois, which is here, and the hindguards, they actually join together at the cloaca. So some of the anomalies will come across when you have now the allantois. Allantois will give us some part of urogenital sinus, and this urogenital sinus will give us the urinary system. So the urinary system and the hindguard, if you don't have acceptation happening there, you'll have now direct connection between the digestive system and the urinary system, and some other anomalies known as evaporateness. We'll come into them in a few minutes. So that was just like a brief overview of embryonic folding and how it will lead formation of the gut tube. So on to our next slide, showing us what I've just talked about. At this point, you can see this is now the longitudinal folding. Maybe now I can emphasize these are lactoids. At this point, you have the cloaca here. These are midguards, these are foreguards, and then these are hindguard. Ideally, you name these three parts according to the location of this yolk sac. So if it's anterior to the umbilicus, it's the foreguard. If it's there, like where we'll have these yolks are coming in, you have that being the midguard, and then if it's beyond it, that's the hindguard. You can see it's happening there. This is now the process of like the whole process after the folding must happen. So you have the lateral folding, the incorporation of the yolk sac, and the visceral parts of the lateral plate mesoderm. So by the virtue, you'll have now, remember this is a visceral part of lateral plate mesoderm. So the mesentery, both the ventral mesentery and the dorsal mesentery will be coming from the visceral part of the lateral plate mesoderm. And then you can see now the endoderm is fully incorporated into this tube. So this tube is what we'll be talking about now. So this tube will extend from the bucopharyngeal membrane up to where we have the cloaca. It's like a straight tube by right now, given that, okay, it's not like a straight tube, given that we have the longitudinal folding happening, so making this thing not to be like cylindrical in nature, but not to be like C-shaped. It's cylindrical in nature, but now the pipe is folded longitudinally in that fashion. Yeah. So I want us to appreciate this, the intraembryonic body cavity. What is the importance of this intraembryonic body cavity? This intraembryonic body cavity will provide room for expansion of these structures. Maybe another point to appreciate regarding the role of dorsal mesentery embryologically, apart from holding these primordial guts, it will allow the neurocrest cells, remember we have the neurocrest cells here, to migrate from the surface, from migrate from the mesoderm at this point, the region around the paraxial mesoderm, into these primordial guts in that virtue. Yeah, and then also remember we have the cells of the yolk sac. So the cells of the yolk sac, ideally at this point in the gut, they will help information of, it's just weird somehow. The cells of the yolk sac will help information of primordial germ cells. So they'll migrate actually from this, they get into the developing the intermediate mesoderm around this region. So we'll have those cells migrating there by the virtue of the dorsal mesentery. So the neurocrest cells get into the primordial gut tube using the mesentery, and then you have the primordial germ cells migrating from the yolk sac. At this point, you call the yolk sac, but again, the point is in an exam setting, right, yolk sac. That's where they migrate into now the developing gonads, the indifferent gonads. Okay, so this like a standard thing. Maybe if you're writing down, these are standard things that I would like us to note. For the whole of the GI, the tissues of origin will be few. There will be about 4 or 5 of them. So one of them is the endoderm, and the endoderm will give us the lining epithelium of the whole tract and the exocrine glands. So the exocrine glands at this point, you're talking about the liver, we're talking about the pancreas, we're talking about the salivary glands. Mind you, I haven't talked about the spleen. So it's the liver, the pancreas, and the salivary glands, and some part of the, and even actually the gallbladder. All of it will be coming from the endoderm. Okay. What about, so I've talked about that liver, pancreas, and the gallbladder, and also at the salivary glands. Then you'll have the splanchnic part of the lateral plate mesoderm. So the splanchnic part of lateral plate mesoderm will give us the smooth muscles. So we talked about the 3 muscles, the muscularis interna, the circular muscles, and the longitudinal muscles. So those 3 muscles will be coming from the splanchnic part of lateral plate mesoderm, and then the connective tissue, and also the spleen. So the spleen, you see, it develops as mesodermal aggregations. So now we have those mesodermal aggregations, they come together, they fuse to give us a definitive spleen, but we'll see that in a few minutes. So spleen is actually, it's a unique structure that doesn't come directly from the endoderm. Then maybe I need to say this here right now, is that the endoderm, we're talking about the endoderm giving us the exocrine glands. We are talking about the parenchyma aspect. We're not talking about the septum transverse. We're not talking about the capsule or the trabeculae thing. You're just talking about the parenchyma aspect only. And then you have the neurocrest cells. The neurocrest cells, we talked about them migrating from the region around the paraxial mesoderm into this developing primordial gut tube to form the enteric nervous system. Maybe to remind us, the enteric nervous system comprises of 2 things. You'll have the mesenteric plexus in the submucosa, and then the myenteric plexus between the sacula and the longitudinal muscles. The function of mesenteric to allow the secretions to regulate the secretions or to simulate the secretions of the submucosal glands, and then the mesenteric just enables the process of peristalsis, the mass movements to happen. Okay, and that's the reason why if at this point if the ganglions which are coming from the neurocrine cells they can be absent, you can have a disease like Hirschsprung's disease. We'll be able to see that in a few minutes. The Hirschsprung's disease, also known as congenital ganglionic megacolon. So absence of those ganglions, absence of the enteric nervous system, or even reduced, will lead to presence of this congenital aganglionic megacolon. So aganglionic meaning there's absence of the ganglion, and then mega because we have accumulation of food, and then which part specifically the colon, which is most of the time the sigmoid colon is one that usually affected. Then we'll talk about the ectoderm, giving the origin to the stomodium, that is the oral cavity, and then the proctodium, the cloaca, the region around the cloaca. So the anal region, so the distal aspect of the cloaca, the proctodium, will come from the ectoderm, and that's the reason why it will be stratified squamous, non-keratinized epithelium. Okay, so we'll talk about the divisions of the GI. This one I'll just like skip it because we've talked about it, but maybe you can just see it. This is the stomodium, this is the proctodium here. And then as I'm talking about this, you can appreciate the hindgut is joined together with the allantoid here, the cloaca. So you need to separate or need to divide this cloaca into two so that at least you can have anteriorly the urogenital system and then posteriorly the hindgut, that is now the anal region. So failure to that will see some anomalies coming across. So the foregut develops from the pharynx. Remember, this is the pharynx. And actually, this is the pharynx. This is developing pharynx. So it means the pharyngeal apparatus, the 6 of them, will be developing on either side of this pharyngeal tube. So if they're developing from either side of the pharyngeal tube, that means the neurocrine cells already migrated there. And then the neurocrine cells, after giving rise to this pharyngeal tube, pharyngeal apparatus, sorry, they will now migrate to the head and neck region. Remember at this point, you're having the cranium being just membranous only. It's just membranous in nature. So due to now the migration of the neurocrine cells, you have the osteoblasts being formed, forming the cranium. And now this is around now the around week 5 to week 9. It's happening at around week 5 to week 9. So let me not talk about the development of the head and neck region. Maybe feel free to go and watch the video on the development of the exoskeleton. You can get a deeper understanding on the development of that. So for the foregut, we'll have it developing from the pharynx up to the second part of the duodenum. So how do you know the second part of the duodenum? You know the second part of the duodenum when actually you see the ampulla ovata in an adult. But now at this point, when you see the primordium of the liver and the pancreas, just know that that's a part that will give us. That's the second part of the duodenum. Okay, so then the midgut. Now you start from the second part of the duodenum up to the region around now 2/3 of the transverse colon. So you will see that part when you have. Okay, let me not talk about this right now about the points of the midgut. Allow me to talk about them when you're having the rotations of the midgut, so at least you can be able to explain it there. But just know the midgut extends from the second part of the duodenum to half or a third or 2/3 of the transverse colon. That will be also demarcated according to the blood supply. Then the midgut is connected to the yolk sac. You can appreciate this yolk sac here. So its connection will be via the vitelline ducts. So it's supposed to degenerate. If it doesn't degenerate, you'll have the markers, the reticulum, and the rest of the vitelline ducts anomalies. Then the hindgut now from the region you have the transverse colon to the cloaca or the anal tube. So at this point, I hope you can be able to relate what is when we're talking about stomodium. What are we talking about? The future mouth. We're talking about the cloaca, the future anal tube, the future anus, the future urogenital system. And when I'm talking about the pharynx and the stomach, like at least you can be able to figure out where they are right now. Okay, before I proceed, maybe you can give me a thumbs up if we are together. Can you give me a thumbs up if we are together? Or just comment something in the chat box if you can be able to do that. Or ask any question. Okay, thank you, Katrina. So you can go to the next point is now explaining splanchnic circulation. So remember the foreguards, the midguard, and the hindguards. Each of them, they are supplied differently. So we have developing aorta at this point. This is a heart. You can appreciate this is a developing heart. So the developing heart, it will be the process of angiogenesis is happening. Angiogenesis is the development of the blood vessels. So angiogenesis is taking place. So as angiogenesis is taking place, you'll have three major arteries coming in. One of them will be the celiac trunk, the celiac artery, supplying the foregut. Remember the foregut we talked about, the distal aspect of the esophagus up to the second part of the duodenum. Then the superior mesenteric artery will be supplying the part that will be going to form the part that will develop into the yolk sac, the one that will herniate into the yolk sac, the physiological herniation. So you'll have physiological herniation. Remember, this primordial gut tube is developing faster, so we'll have it herniating into this yolk sac. Or it will herniate into this umbilical, into this vitelline duct that you can see here. So due to its herniation, an artery develops, the superior mesenteric artery, it will develop due to that. And then the last one is now below the herniation, we'll have the inferior mesenteric artery, now supplying from now the transverse colon up to the region where you have the cloaca. And that is being shown now in the image on our right. So you can see the celiac artery supplies the liver using the hepatic artery proper. You can see the stomach by the various arteries. You can see even some part of the pancreas. So the distal aspect of the head of the pancreas will be supplied by superior mesenteric artery, while the inferior aspect of head of pancreas will be supplied by superior mesenteric artery, while now the superior aspect will be supplied by the celiac trunk. You can see the small intestine majorly by superior mesenteric, and then even the ascending colon and some part of the transverse colon by superior mesenteric. Then the rest by the inferior mesenteric artery. Yeah, maybe to mention a little bit, you can appreciate at this point, you have the developing lungs, and during the development of the respiratory system, I hope we talked about, you'll have the lung buds ideally developing from the anterior aspect of the pharynx. So the lung buds migrate from they develop from the anterior aspect of the pharynx, and then they descend down. So ideally, the lungs, the lungs, the parenchymal aspect of the lungs comes from the endoderm also, and then you'll have the capsule of the liver coming from the mesoderm. So ideally, both of them will have similar origin, but we'll talk that in our next slide. But we can appreciate the blood supply of the proximal aspect of the esophagus will be different because you'll have the superior thyroid glands, inferior thyroid glands coming in to supply the descending thyroid glands, and now that's how now it comes into play that they will be supplying this esophagus. So allow me to go to the next slide. which is ideally talking about the blood supply of the GI. So I don't know if you have time, but I can see time is far much spent. So allow me to just mention these arteries as fast as possible, so at least we can be able to save on time. So this is actually the structure that is applied by the celiac trunk. So this is actually like the foregut. So this is a celiac trunk coming from just the upper part of L1. At this point, even you can appreciate. So this artery is actually now the two phrenic arteries, two inferior phrenic arteries that now go supply the that. But you can appreciate we'll have the major artery, the largest artery of the celiac trunk being the splenic artery, and it's very tortuous, giving us the various arteries, giving us the left gastroepiploic, the splenic arteries, the short gastric arteries in that virtue. And then you have the left gastric artery, ideally to the body of the stomach and also to the distal aspect of the esophagus. And then you have now this is common hepatic artery. The common hepatic artery will divide into two. You'll have the gastroduodenal, and then you have the hepatic artery proper. This hepatic artery proper sometimes can give us the right gastric artery, and then goes ahead and divides into two to give us the right and the left hepatic arteries, and then sometimes you can have the right hepatic artery giving us a cystic artery. You can see this is a cystic artery to the gallbladder. And that's the reason why all of them they come from the same place embryologically. Okay. Anything else? Now you can appreciate this is a pancreas here. The pancreas will be supplied by the celiac trunk. So you'll have this gastroduodenal. The gastroduodenal will will give us the superior pancreatical duodenal branch. And then the inferior pancreatical duodenal branch will come from the superior mesenteric artery. The inferior one will come from the superior mesenteric artery. So that's just a brief overview of blood supply to the foregut. We can just have a look at it at another time. Then for our next slide, we are going to talk about now both the superior mesenteric and the inferior mesenteric. So the superior mesenteric is here. And actually you can see the superior mesenteric. It will give us, first of all, the jejunal branches, the ileal branches, and then it can even the ileocolic branch. You have an ileocolic branch. This ileocolic branch will go and supply the distal aspect of the ileum. Will give us the appendicular artery to the appendix. Will give us sequal branches to the cecum. Then we'll have the right colic coming from the superior mesenteric. We'll have the middle colic here. So the middle colic we supply up to around this point on the transverse column. Then the rest will come across. So the inferior mesenteric now at this point, we will be having three major arteries. The superior colic, superior right colic to now the descending part of the colon. And then we'll have the sigmoidal branches, or they'll be known as inferior right colic branches. You can see them here. And then we'll have this superior rectal, the superior part of the rectum. And so the two parts, the rectum and the esophagus, you can see we've talked about the rectum is supplied by three major arteries. So superior part of the rectum by superior rectal branch coming from inferior mesenteric artery. Then the two parts below it, middle rectal and inferior rectal, will be coming from systemic circulation. Remember, here we're talking about splanchnic circulation. Similar thing, we'll have the distal aspect of the esophagus being supplied by branches from the esophageal branches from the left gastric artery from splanchnic circulation. And then we'll have also some part of it being supplied by some branches that will be coming from the phrenic arteries and also from direct branches from from the aorta. So the actually common places you can have varices. And that takes me to the next image now. Talking so the first two images you talked about blood supply, that is arterial supply. The image now on our left on our right, sorry, shows us the portal circulation. So all the blood system from the intestines, the pancreas, the duodenum, the stomach will go to the liver. So it starts from having the various capillaries, the capillaries in the small intestine and the large intestine and the various veins of the various viscera, they form the various veins. So for example, here you have the inferior mesenteric vein. Inferior mesenteric vein joins this, at this point it joins the splenic vein. And then the vein together with superior mesenteric vein will give us the portal vein. And then the portal vein will drain into the liver. And the liver will drain into, you see now the the three major hepatic veins will drain into the inferior vena cava. So this is portal circulation. Maybe something to note regarding it is that the supply of it will be different from the supply of the viscera of the GI will be different from the supply of the various parts because these ones will drain into the liver, the rest will drain directly into the superior and inferior vena cava. So what is the importance of that to enable the substances in the nutrients coming from the viscera to go into the liver for metabolism. So remember the liver is the major organ for metabolism. That's where metabolism usually happens. And so they have different pressures, given the fact that they don't have something like that. They have a lower pressure. And if you have no difference in, ideally they have a lower pressure of about 10 to 15 milligrams of millimeters of mercury, while the venous circulation is about 40. So difference in pressure, if you can have no maybe an obstruction of either of these, you can have portal hypertension. Portal hypertension gives you no accumulation of fluid or blood into the interstitial fluid into the viscera, and then that's how you can have ascites. That's how you can have rectal varices. That's how you can have esophageal varices. Yes, and allow me to mention this here that you're supposed to know the six places of photosystemic anastomosis or photocaval anastomosis. So we talked about two of them right now. Maybe also mention about the region around the umbilical, so you have the parumbilical vein. Talk about which part of the liver has that anastomosis. Talk about the vein of Retiers, the one that joins the inferior mesenteric directly to the inferior vena cava. Yeah, and now the renal vein and even the lumbar veins can join, giving us can join together the inferior mesenteric, giving us another point of photosystemic anastomosis. So photosystemic anastomosis is also known as photocaval anastomosis. So there's no difference there. But it is a very nice slide. You can take it, you can have a screenshot of it, then try to label the various arteries. I've tried to name as much of most of them. Okay, so I'm not quite sure if I'll be able to be done with this session. Maybe if I won't be able to be done, you can have the remaining part next week. But let's talk about the foregut. So the foregut, we've talked about the region from the pharynx up to the second part of the duodenum. So that is now the esophagus, the stomach, D1, that is the first part of the duodenum, and the proximal part of D2. And the glands that will be coming from the foregut will have the liver, the biliary system, and the pancreas. And then also the lower respiratory system, that is the larynx, the trachea, the bronchial tree, and the lungs. Ideally, the parts that come from the lung bud. So as we are talking about the development of the foregut, we'll also talk about the lung buds developing downwards. Yeah, so the tracheobronchial diverticulum that develops downwards, then it undergoes the process of septation. Failure of the septation will have the TES, tracheoesophageal fistulas. So what is the site of development of the esophagus? I'll try to hurry up, Kidogo, given the fact of the time is somehow not on our side. The site of development will have the foregut. Yeah. Apart from having it, will talk about the tissues of origin. The tissues of origin talk about the endoderm, giving us the epithelial lining and the glands. We talk about the esophageal glands in the submucosa. Then we'll have the splanchnic mesoderm will give us the connective tissue elements and the smooth muscles, the three pairs of the muscles that we talked about. Then we'll have the neurocrest cells giving us the enteric nervous system. And then it will also give us the respiratory diverticulum, the lung bud. And this is what I'm talking about now. So you'll have the respiratory diverticulum, the lung bud, developing from the pharynx. So it goes downward. So what will happen is that we'll have constriction. So they'll be known as tracheoesophageal ridges. So those ridges, they will develop towards each other and then they'll fuse. When they fuse, they'll form like a septum, and then that septum separates the pharynx from the trachea. So that's just a brief overview of the process of septation of the respiratory diverticulum from the primitive gut tube. And the respiratory diverticulum forms in the ventral foregut, that is tracheoesophageal septum, we talked about it. And then the endoderm now. So before we talk about this endoderm proliferating, at this point we've already separated the tracheobronchial diverticulum, the lung buds, from the primordial gut. So at this point you have the primordial gut, the pharynx. What will happen is that we'll have the endoderm, the inner lining of it, undergoing proliferation. It will proliferate to give us a solid stage. To give us a solid stage. Why are you having this proliferation? It will proliferate more than the splanchnic mesoderm, and that's the reason why you'll undergo the process of like the pharynx becomes like solid because of that. And this one will form a very important step in the in some of the anomalies that we'll talk about. Then after having the solid stage, the splanchnic mesoderm will develop also, now enabling the process of recanalization to reestablish the lumen that has been closed in this solid stage of the development of the esophagus. So this is it. We'll have the laryngeotracheal opening, which opens in the primordial pharynx. Then you can appreciate at this point, you'll have the groove being formed, the ridges being formed. They fuse then to form the septum, and then they will separate completely. So when you actually have the separation completely, this tube will be known as laryngeotracheal tube. And then this laryngeotracheal tube will form two bronchial buds. The bronchial buds now will go and form the two respective lungs. So allow me to go to the next slide. So at this point, showing us the esophageal lumen in the fourth week, splanchnic mesoderm surrounding it, and then at this point have the columnar ciliated epithelium from the endoderm. So due to proliferation of the endoderm, we'll have the solid stage coming in. So this is a solid stage, obliterating the lumen, and then after that, now we have the development of the splanchnic mesoderm. So remember the splanchnic mesoderm. Remember this happening sequentially. We'll have the splanchnic mesoderm will give us the submucosa, inner circular, the outer longitudinal muscles, and even the adventitia. So this one is happening at this point now. The image on our right side. This is now the adult esophagus. So that's it. So what happens if you have an abnormal septation? If you have an abnormal septation, you'll have these anomalies here: the tracheal, esophageal fistulas. Okay, you can have esophageal atresias with or without tracheoesophageal fistulas. So the first one is a normal anatomy. So at this point, the normal septation happens, and that's the reason it's a normal anatomy. In this, you can appreciate there is esophageal atresia. So atresia means complete blockage or absence of connection between a tube. So there is no connection between the proximal part of the esophagus and distal part of the esophagus. Why? Because septation didn't happen. Right? So at this point, you'll have esophageal atresia with distal tracheoesophageal fistulas. This one is now esophageal atresia with both proximal and distal TEFs. Then this one is proximal. Then this one is esophageal atresia without TEF. And then you can have now this tracheoesophageal fistulas. Yes, the septation happened, but now you have an abnormal connection happening. So those are the anomalies. We'll come into this image in a few minutes, but because we're supposed to know which one is more common, which is the least common, which one is common in Caucasians, which is common in the Negros, and such things. Okay, then the other anomaly on our right is showing us the hiatal hernias. And the hiatal hernias is now where you have some part of the stomach getting into the thorax. Why? Because of the esophagus didn't elongate. It was small. And then due to now the force, the pharynx is fixed on the neck. So we'll have some part of the stomach undergoing herniation, a process known as hiatal hernia. Yeah, so this one happens when the esophageal opening. So we'll have another slide showing us some of other openings that will be present in the diaphragm. Then the other anomalies here we can appreciate. This one is esophageal atresia. Why is this? Why is it esophageal atresia? Remember we talked about the solid stage. The solid stage that we talked about. After having a solid stage, we have recanalization. So abnormal process of recanalization will give us either esophageal atresia or esophageal stenosis. So esophageal atresia means esophagus is completely like it's food can't pass by. You have a blind end. While in stenosis now you have the narrowing. So at this point, this one is atresia. Stenosis is like this one now. Can appreciate. Maybe there is a web. If the web is completely covering it, you'll have as it will have it as a atresia. If it's not completely covering it, we'll have a stenosis. Yeah. So that is it. You can appreciate presence of this fibromuscular stenosis. So this one is esophageal stenosis. The image on our right, it shows us the duplication of the esophagus. So the person has two esophagus. Of course, one of them is like a vestigial structure, but the fact is the esophagus is there. They can't be functioning both of them, but one of them uh, is, well, like you have two instead of one. Yeah, and that you can see it here. So you have, these are thoracic vertebrae. If you can take maybe an X-ray, you can appreciate you have two. So this one is a transverse cross section of a drawing showing us the two esophagus. Okay, then at this point you can see the tracheoesophageal fistulas just happening here. So they don't only happen in the esophagus, they can even happen in the small bowel, the small intestine. Yeah, so they can join directly now to the anterior abdominal wall. This is actually an abdominal link. They are rare anomalies, but they can be there. So this one is just showing fistulas to the small bowel, they can be to the large bowel. So we'll talk about things to do with Marcus diverticulum. But it was trying to explain the concept of the fistulas. Then this one is now atresia, esophageal atresia. You can see this one is esophageal atresia with maybe this one is bronchogenic cyst. You covered it when you're doing the development of the respiratory system, but you can appreciate you have esophageal fistula here. So this is a proximal part of the esophagus having an atresia. It's atretic in nature. The distal aspect is connected to one of the bronchi, as you can see there. And then this image is trying to show us maybe you can also have the umbilical, not umbilical, you can have um, like presence of abdominal structures into the thorax, the ventration of the diaphragm. You can see these abdominal structures inside there. So the ventration of the diaphragm. Yeah, not only, so remember you can have diaphragmatic hernias and eventration, and that one you can be able to assess it. You know those two images are usually there. So for the eventration of the diaphragm, we have a membrane. Then for the diaphragmatic hernias, we have now this organs of the GI, that is the abdomen, will join directly to the structures of the thorax. So there's no membrane. Okay, so up to this, allow me to skip this by just mentioning the one that is most common is the esophageal atresia with distal tracheoesophageal fistulas. Then the least common actually at this point, they can either be the one that has dual, that is double, or proximal and distal tracheoesophageal fistulas, and the proximal tracheoesophageal fistulas. But these things are corrected surgically. So the reason I had to talk about esophageal atresia here is just to say that this esophageal atresia doesn't come across as a lone thing. It comes with a syndrome of malformations known as bacterial syndrome, where it will have the vertebral anomalies such as the hemivertebra, scoliosis. You'll also have the anal atresia, the imperforate anus. We'll cover that today. Cardiovascular anomalies, most of the time, is ectopia codis. Then we have tracheoesophageal fistulas, we just covered that, and esophageal atresia, we just covered that. Then we talk about the renal and radial anomalies. So for the renal, most of the time is horseshoe kidney. Then for the radial anomalies, usually develop dysgenesis of the radius bone. Maybe you can have radial atresia, radial dysgenesis, something like that. Then for the limb deformities, usually clubfoot malformations. Yeah, so that is just the bacterial syndrome. I put this slide just to enable us to understand things to do with the development of the esophagus. Remember at this point, you can have the structures of the abdomen getting into the esophagus, the thorax, sorry. They can either get in, either using this esophageal opening or this botchdale opening, giving us the botchdale hernias, and then they can also get in using the foramen of Mogagni. So Mogagni hernias. So the two, botchdale and Mogagni, they will give us either the ventration of the diaphragm or the diaphragmatic hernias. So those two, they're actually abnormal, but they are present. They are present even in a normal person, but the size is small. They're very small. But if they become elongated, if they become large, they can give us those hernias. Okay. So I don't know if there is any question Anyone with a question? If you don't have any question, can you allow me to go to the next slide and talk about the development of the stomach? Okay, I don't know if you're getting it. Are we getting it? Okay, the good thing is that I know you guys, so nakutaja tu slide. So, gift, are you getting it? Okay. But nataka gift aniambie kama anaelewa. Gift unaelewa kitu? Sawa, sawa. Najua wewe ni legend. Legend wa kupata hizi vitu kwa haraka. So, that's okay. Okay, so we can now go to the stomach. Let me just see how far I am in terms of covering the slide. Because I know I'm quite behind in terms of the time. So I'm in slide 21 out of 57. So I'll go up to slide number around 35, up to, allow me to go up to where you have the anomalies of the stomach. Then we'll continue from there next week, because it's quite a lot, quite a lot. So allow me to go up to the stomach, then we'll talk about the rest next week, because it's quite a lot. But I finish up to where you have the small and the large intestine, so that next week we just start from the glands. Okay. So for the next few minutes, allow me to be as fast as possible, so that at least they can save some time for the questions and other things. So for the stomach, it will develop from the distal part of the foregut. Remember at this point, we say the stomach is a derivative of the foregut. So it will be coming from the distal aspect of the foregut. So the tissues of origin will remain the same. Endoderm giving us the lining epithelium and the glands, mesoderm giving us the connective tissue and the smooth muscles, and then the neurocrest giving us the nervous plexus. Then for the stomach now, and maybe this one I would like us to be keen. Can you be keen in this? Because if you understand this, you'll be able to talk about the origin of the falciform ligament, the origin of ligamentum venosus, the origin of the transverse mesocolon and such things. So can you be keen in this? So this is the lateral body wall. You can appreciate this is the lateral body wall. Yeah. These are the two kidneys. These are the two kidneys. But remember the kidneys are retroperitoneal structure. That's the reason why these are the two kidneys. So these organs, ideally, I want us to imagine like these organs are developing from the posterior abdominal wall. And this posterior abdominal wall is covered by a membrane. This membrane will call it peritoneum. So if they are growing from the posterior abdominal wall, they are pushing this membrane. They're pushing it anteriorly. So the structures that will get themselves into it will be known as intraperitoneal structure. The structures that are not in this peritoneal, they are just covered anteriorly by this peritoneum will be known as retroperitoneal structures. One of them is the kidneys. At this point, you can appreciate the kidneys, the anterior part of the kidneys are just covered by the paratoperitoneum. Then there is a visceral peritoneum. So we have the kidneys here. We have the liver, the stomach, and the spleen. So at this point, they are developing inside this visceral part of peritoneum. So anteriorly, so you have the stomach here. So the mesentery that will just be anterior to the stomach will be known as the ventral mesogastrium. Then the one that is posterior to it will be known as the dorsal mesogastrium. So the transverse colon, the spleen, the pancreas will be attached to the stomach using the dorsal mesogastrium. So the greater omentum, the transverse mesocolon, all of them will be coming from the dorsal mesogastrium. While anteriorly now you'll have the falciform ligaments, the coronary ligaments, they'll be coming from the ventral mesogastrium. So this is the falciform ligament. At least you know the falciform ligament attaches the liver to the anterior abdominal wall. And actually you can see it here. So the ventral mesogastrium will give us those structures that I've talked about. Then posteriorly, the dorsal mesogastrium will form the structure that I've talked about. So they're actually somewhere in a straight line here. So if you can remember earlier, I mentioned something to do with the spleen coming from the splanchnic mesoderm. And where does this mesentery come from? It also comes from the splanchnic mesoderm. So it tells you have just the cells of the splanchnic mesoderm aggregating in the mesentery to give us the spleen. And that's the reason why the spleen will be intraperitoneal structure. So how do you remember now you have this tube in the mesentery. So the tube in the mesentery, to be specific, the one that will form the stomach will undergo fusiform dilatation. So it will expand. You know how a fusiform looks like, how a fusiform shape looks like. But we'll see that in a slide. It will be suspended anteriorly and posteriorly by the dorsal and ventral mesogastrium or the mesentery. Then you'll have a differential growth. So differential growth in terms of one part of the stomach, the anterior part will develop slowly. The posterior part will develop faster. So the posterior part grows faster while the anterior part develops slowly. And that's the reason you'll have the lesser curvature being smaller and the greater curvature being larger. So after you had the differential growth, this results in curvature formation, and then you have now the rotation of the stomach. It will rotate. And then it will rotate in the vertical axis about 90 degrees. So you can see the rotation that is being taken there. So if you have now this, you'll have now the posterior part being on the left side and then the anterior part being on the right side. And this is now what you have. So you have the fusiform dilatation here, then the differential growth giving us the lesser curvature, the greater curvature. And then after that, now you'll have the J-shaped structure of the stomach coming in. Yeah, so this is it, just to try and show us how those structures develop. So the liver will go to the right side, then you'll have the spleen going to the left side, the stomach being at the center. You can see it there. Yes, I don't know if there is any questions regarding the stomach, because ideally at this point, if you talk about the fusiform dilatation, the differential growth, the rotation, you're done with the development of the stomach. So maybe now the nitty-gritties, development of the gastric glands, which will be coming from the endoderm, such things. Yeah, but right now I'm just trying to mention the most important things. I don't know if there is any question right now. Okay, let me mention someone else. Tebelo, tuko sawa? I don't know if Tebelo you can be able to hear me from the end. But are we good? Okay. Okay then. Let me repeat the overview of the stomach then. So I won't mention things to do with the ventral and dorsal gastrium. At this point, you have the primordial gut tube that you're talking about. So it's found in the in this developing embryo of ours. So the point specifically that will be forming the stomach, ideally there's a lot to this. There's a lot to this. So if you want to know how now to know which part specifically will form the stomach, maybe now you can do BSc, because that's BSc content. because you have molecular aspects. The Hox genes, the W and T genes will come across. The various concentrations of them will determine which part will form the stomach. But now at our point right now, we just need to know like the distal aspect of the foregut will undergo dilatation to give us this. This is the fusiform dilatation we talk about. Just expands the distal aspect of the foregut undergoes dilatation. So if it undergoes dilatation, that after dilatation you have it undergoing differential growth. So the differential growth will be posterior aspect develops more than anterior aspect. That will lead to formation of the lesser curvature and the greater curvature. After that, you'll have the stomach undergoing rotation. So the rotation will be 90 degrees in such a way that the anterior part will be now towards the right side. Then, so actually in this slide and most of the X-rays images, maybe I can try to tell you right now. In an X-ray, at least you're looking at this image from above. So in this point, our right will be this. In such a slide, our right will be this. And that's the reason you can see the liver is going to the right side. The stomach is somehow, the anterior side is going to the right side. Then the posterior side is going to the left side. So in an X-ray image, and maybe in some embryological anomalies like this one, just trying to explain the rotation, the right side is always like, it's like you are inverted. So your right side, your right hand points to your left side, and then your left hand points to the right side. So I hope you've noted what I've said. So it's like you're looking this image from an anterior aspect, like unaangalia kutoka juu. So if you're looking it from kutoka juu, the liver at this point will be going to the anterior aspect. Actually, if you can use this image, you can use this image. It's telling us that the liver will go to the left side, and yet we know this side is the right side. So in an X-ray image or in some embryological anomalies, always trying to look which side are you in, especially if you're trying to talk about the position of the liver in an X-ray image. So always try to be inverted in that patch. Just try to invert. It will help you in understanding. So that's the reason why at this point you're saying the liver will go to the right side. The anterior or the anterior border of the stomach will go to the right side. Then the posterior border of the stomach will go to the left side. And then you can see the spleen which is found on the left side at this point going towards this direction. Yeah. So now we can talk about a few of the anomalies. Yeah. And for the few of the anomalies that we'll talk about today, we'll have this. So you can see this is the pylorus. So the pylorus can undergo hypertrophy. So remember one of the changes, one of the histological changes that happens from the stomach to the duodenum is the hypertrophy of the pyloric sphincter. So the muscles can hypertrophy in such a way that they can close the lumen, or they can almost close it. So you can have pyloric stenosis or pyloric atresia. So in a person with pyloric stenosis, the person will have projectile vomiters. You can see these projectile vomiters. And then these projectile vomiters, it won't be having any blood. And this one will be detected in the first few months of perinatal, the first few months after birth, perinatal. And the reason is due to pyloric, so hypertrophy. So this anomaly is known as congenital hypertrophic pyloric stenosis. Okay, and then you can appreciate now at this point you have complete obliteration, like you have a blind end. So this is pyloric atresia. So the first about the first 6 images just show us pyloric atresia. And even this is pyloric atresia. Then these two, they're actually stenosis. So for stenosis, it's just narrowing. Atresia, complete blockage. And the blockage can happen due to either you have a membrane, a mucosal membrane covering it, or you're having the two tubes being disconnected, like these two. You can appreciate these three are disconnected continuously. Or you can have the two being joined together by maybe a fibromuscular tissue. Or maybe you can have now a muscular web joining them. So this one you can see there is a muscular web joining them. And then in this complete abscess. So maybe if I don't know if right now you can have such a question ask me. You can ask you talk about the different types of pyloric stenosis. So you can mention about pyloric stenosis with a fibromuscular branch, with a with a mucosal web, or maybe now the hypertrophic one, which you're saying here. And then the other one, maybe I can try to explain this here, the two images here on our right side. You can appreciate this is the cardia of the stomach. So the cardia of the stomach, this is esophagus coming in. But you're seeing the body, like this is not the normal shape of the stomach. This is actually an abnormal shape of the stomach. So these are just variations in the shapes of the stomach. The various variations in the shapes of the stomach. I don't remember the name specifically, but you can have abnormal. These are just abnormal morphologies of the stomach. I don't remember the names because it doesn't have like a specific name. Yeah, but this is what you can have in nothing. I don't know if you can have it in an exam setting, but they're just very abnormal morphologies of the stomach because you can see where the pylorus is. You are expecting the pylorus to be found on the distal aspect, but now it's here. Okay, so how many minutes? It's 9 minutes to 10. So can we continue or yeah, that is gut malrotation actually. Okay, it's not like completely gut malrotation, gut malrotation, but because for the gut malrotation is something different, but you'll come across of course due to gut malrotation, but it's not majorly that. These are just the different morphologies of the stomach. Let me confirm the name right now. Just a minute, give me a minute. I confirm the name. Yeah, the name is gastric inversion. Yeah, the name is gastric inversion. That's the name of these things. Okay, should we continue or we stop there? Maybe you're the one to tell me. Should we stop there or we continue? So regarding looking at the image, you can be looking at it. Personally, what I know is you're looking at it from from above. But the best one that you can use is just like your right hand points the left side, and then the right hand points the left side, and then the left hand points the right side. That's the best way to use. Other than saying that you're looking at it from below or maybe from above, just invert your hands, and then you'll be good to go. So should we continue or tuachia hapo? Because I know some of us to be have had some busy schedules. Maybe Macrono, you can tell us, should we continue? I want to tuachia hapo. Okay. We continue up to 10. Okay. That's okay. So if you're talking about going up to 10, ideally, honestly, I won't be done with describing the development of the small and the large intestine. Maybe if anyone has questions, or let me look for a structure that is simple to develop. Let me talk about the development of the spleen right now, because it's kind of simple. Okay, just 3 slides. So for the spleen, I had alluded it being formed in the between the lens of the dorsal mesentery, that is a visceral peritoneum. So you'll have mesenchymal condensation, the same way we talked about secondary neurulation being formed, the secondary neuropathy being formed by mesenchymal condensation. The same mesenchymal condensation will develop here. The difference is for the neurotype, the condensations usually come from the region around the paraxial mesoderm. But now at this point, they'll be coming from the splanchnic part. So the mesenchymal condensations, they'll come together, the cells will aggregate between the layers of the dorsal mesentery. There'll be about 5 to 6 of them. So ideally, the 5 6 aggregations they're supposed to fuse. That is that is what happened maybe to your spleen, to my spleen. That is, I'm talking about maybe. So if they fuse completely, they give us a definitive spleen. So that spleen at this point, it will be formed by both the parenchymal aspect of it and the stromal bit of it will be formed by splanchnic mesoderm. Then they'll be enveloped by this greater omentum. So remember, the greater omentum is now coming from the greater curvature, because we talked about the greater curvature being found on the posterior border. So this is a greater curvature that you're talking about. Then is a pancreas. So it's here is a greater omentum that is covering the spleen. So then, due to rotation, it goes towards the left side. So migrates to the left side due to gastric rotation. So due to the rotation of the stomach, the 90 degrees in a vertical position enables the spleen to go to migrate to the left side. Maybe now, at this point, you have a definitive spleen that is solid in nature. So what happens if you have failure of development of the spleen? So complete absence of the spleen is known as asplenia. Complete absence of the spleen is known as splenia. Asplenia, sorry. So that is now in how we didn't have the spleen developed. The other one is that you can have different, like the spleen, the various aggregations, they didn't fuse completely. So that means the spleen will be, you'll have these things here. You'll have these lobulations of the spleen. So this one is lobulated spleen. So yes, they attached, they fused, but they didn't fuse well. And then in this image, now the middle image, it's just showing us the presence of accessory spleens. The spleens are there. The, 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 the aggregations didn't fuse completely, ideally. So you can see them there. The aggregations didn't fuse completely. That is just having the lobulation of the spleen. So maybe to draw us back to the normal anatomy of the spleen, the superior border is the one that has notches. So the notches are supposed to be 3 or 4, 1. Okay, 1, 2, 3 to 4. So absence of that, or maybe absence of that is not an anomaly. But the notches can be more than, you can have up to 7, up to 9 notches on the superior border in a normal spleen. So if they go beyond that, now we have lobulations of the spleen. At this point now you can see this image is just showing us an accessory spleen. And most of the time, this accessory spleen develops at the region around the hilum of the spleen of now our major spleen that you're talking about. Then this image just tries to show us the lobulations on the spleen. At this point, this one is having hyperlobulations. Then you can see these are now the accessory spleens here. And then there's the tail of the pancreas. Remember, the tail of the pancreas makes an impression on the hilum of the spleen. Yeah, sometimes this spleen can actually go and merge with the testes. So if you didn't have the descent of the testes, if you didn't have the descent of the testes into the scrotum, an anomaly that is known as cryptorchidism. So it means now then you have accessory spleen. You can have the spleen and the testes merging. So if you can do maybe histology of such a tissue, you find both splenic tissue and testicular tissue being there. But they are rare anomalies, but you can find them developing. Yeah, so that is just the development of the spleen. Just a very small thing. As long as you talk about its tissue of origin, lactic mesoderm, then the process will be mesenchymal condensations. There are about 5 of them. They fuse, then due to stomach malrotation, it goes to the left side. Yeah, some of the anomalies are splenia, hyperlobulations of the spleen, accessory spleens, and fusion of the spleen to other tissues such as the, the testes. Yeah, so that's majorly it. So actually, most of the anomalies that we have in the GI, they'll be somehow X-ray. Most of them will be X-ray. Yeah. So actually, at this point now, you can see the reason why I'm saying this is the left side because you can see multiple spleens. This is the right side because you can see the liver, and then these are the two kidneys. So this one is the right kidney. This is the left kidney. Why? Because you can see like the right kidney is actually below the liver, and actually at a lower level than the right than the left kidney at this point. Yeah, and then now you can even try to see Kina psoas major, Kina quadratus laborum. Yeah. So that's it from me. It's 22:02, so can you allow me to stop from there? Maybe we meet next next Sunday. Okay, I'll just see over the course of the weekend next week. Nitajua time yenye nita create two time where we'll just go through the remaining. But it's quite a lot. I presume I've covered about like almost half. Um, but I've laid a basis on regarding the development of these things. So the most of the anomalies that will come, they won't be the ones that we've been talking about. Zenye sasa tutacover toka next time ndo most of them ndo zitakuja sasa. But in this one actually, I wanted to show us this is now the diaphragmatic lining. So you have the structures of the abdomen getting into the thorax. So go and check now on an image to do with eventration of the diaphragm. So this is diaphragmatic lining. Yeah, but I'm sure you covered it when you're doing the development of the respiratory system. Okay, so that's it from me. I wish you a good